quick run of sodium very quickly, just to have a recap so that you have a refresher in your mind. And it is about sodium handling by the kidneys. You know the sodium concentration in the extracellular fluid. Okay? The most abundant positive ion in the ECF is sodium. We all agree on that. And it varies somewhere between 135 to 145 or up to 150 even in some of the labs. It's okay. Renal functions, if you remember, we discussed also regarding sodium control. But before that, we talked about what is the role of sodium in the body and why it is important to keep the sodium balanced. And you gave the answers that it is required for the excitability procedures in the body. When you say the word excitability, you're talking about nerves and you're talking about muscles. Okay? So, when excitability comes in your mind, always bring the word neuromuscular excitability about the nervous tissue and about the muscular tissue. These two are the excitable tissues of the body. Both are controlled by sodium and potassium ions, you know that. Okay? So any deficiency in potassium or sodium or excess of sodium and potassium will definitely bring about a disturbance in the function of nerve tissue or the muscle tissue or both. Okay? It depends. Sodium kidney, look at the picture. Look at that part which is for the sodium. And you can see, and as you already know, most of it proximal to view. Rest of it, major amount, loop of Henle, thick loop of Henle. And at other stations, there is a little variable amount which is reabsorbed. Okay? Potassium was discussed earlier that potassium was secreted. But do you think sodium is secreted? No, we did not say that, and it is not a fact. Okay? So no secretion is mentioned here. It's only reabsorption, and the rest of it is going in urine in little amounts really. Okay? So most of it is reabsorbed. A very little of it goes in urine as a regular event. We showed very quickly about different procedures, different modes of transport which you already know, which is happening with the sodium. Sodium is helping so many things. Along with its own transport, it is helping the other ions, organic as well as inorganic. Essentially, the nutrients like glucose, amino acids, vitamins, they are taken with the help of the sodium. And as a counter procedure or as a co-transfer procedure, many inorganic ions are also reabsorbed along with the sodium, or they are secreted or moved out with the help of the sodium. So sodium is a great helper really everywhere. Proximal tubules, early and late proximal tubules, you can see many procedures. There is sodium taking part in active transport in primary and secondary both, and in the passive procedures also. You know that, right? So I'm quickly moving over the slides because these already had a discussion previously. Thick ascending loop of Henle, a very, very important area where you have a very focused pump, a very efficient pump which is working. Again and again, it's good to discuss this pump. This is triple transporter, a sodium potassium 2-chloride transporter or a tripod, and that is moving three very, very important types of ions. In fact, 4 ions at one time, but 3 different types of ions, right? You know that. I think you had a question on that also, yes? Okay. I hope you have not done it wrongly. Okay. Because sometimes students are confused 3 or 4. 3 means what and 4 means what, you have to distinguish between that. Okay? Anyway, distal convoluted tubules also have a special co-transport of the sodium along with the chloride. All these special transports are affected by different diuretics, as you know that. Okay? They are the site of action, site of blockade of different diuretics. It may be loop diuretics or it may be the thiazide diuretics. Later on you will see more. The channels are blocked by triangularine and amiloride also, if you remember. So, aldosterone antagonists are also working. This is the late distal tubule and the collecting ducts, basically, the cortical specifically. And you can see again, sodium is very actively working here also. So sodium is magnificent really in its work. Excellent. Sodium, well, intake is controlled by a very special thing, which is hypothalamus, and it's our psyche that requires sodium. Whenever we are short of sodium, we desire sodium. We have a psychological feeling that we must eat something which is containing salt, and we look for that, and we find that, and we eat that. Okay? So this is the way. When we have hyponatremia or hypovolemia, or whenever the sodium is getting imbalanced or low in the body, whatever the reason may be, you will have this desire coming from the hypothalamus. And this needs a proper working of the hypothalamus. Yes?
Hypovolemia, wouldn't be there a stimulus for first center rather than the appetite?
Well, sometimes, it's a two-in-one procedure which is going on. Hypovolemia is targeting two things at the same time. Okay? Not only it stimulates the third center, definitely through the baroreceptor, but at the same time, it detects that there might be some deficiency of the sodium going on along with that hypovolemia, because when you are losing the volume, you must have lost some sodium also. So just in order to cope up with the situation, what happens that it's a double target. It's going to two centers which are located side by side in the hypothalamus, very close to each other, and there are many connections which are stimulating both. So by one stimulus, you are getting two responses. Okay, so that's why it happens. Okay, but definitely thirst is there. Okay, for thirst, you are getting the volume back. But in that volume, if you also want sodium, then you have to stimulate some salt mechanism also at the same time, right? Okay. So this is about the input or the intake of the salt. For the output, definitely you are going back mainly for the kidney, but for other areas of the body as well, skin, and these are the areas where you are losing sodium from. Okay? From GIT. We talked about the receptors, okay, which are detecting the volume and pressure, and then they are signaling to the salt appetite center also. The third center and the salt appetite center. And these are the receptors, low pressure receptors and the high pressure receptors according to their anatomical location where they are found in the body. Low pressure regions of the body in circulation, low pressure receptors. High pressure regions where high pressure is modular always, but these are the high pressure. Okay. 1, 2, 3, 4, 5, 6, there are different factors if you see. Some hormonal factors, some ECF factors, and some other renal factors which are there, which are working to handle the sodium or for the sodium reabsorption. Okay, these factors are there. They are working together. One term, glomerular-tubular balance, is very important. It's a very neat and even balance in the kidney at the level of the glomerulus and the tubules. Whenever GFR increases, the sodium reabsorption accordingly, okay, manages, and it does not change in terms of percentage. The percentage remains same. The amount will definitely be more, which is reabsorbed, but the percentage out of the total will remain same. So whether you increase the GFR or you decrease the GFR or you keep it normal, it doesn't matter. The percentage of the sodium which is reabsorbed from whatever you are getting in the fluid, that remains same. This tawazun is called glomerular-tubular balance, because this is a work between the glomerular filtration and the tubular reabsorption which is happening. So it remains same, 65%, 65%. Okay? I'm not saying the quantity, I'm saying the percentage. I think you are getting the point. Okay? The quantity will definitely vary per unit time, because if increased filtration is happening, then total increased quantity is coming as a load and will be absorbed also. But if you're talking about percentage, it will remain same. The quantity will change, but the percentage will remain the same. Okay, great. Procedure of the reabsorption. As of other ions and water, everything is absorbed from the peritubular capillaries in the vasa recta, you know that. And you need a special reabsorption pressure also. And that pressure has to be maintained so that you have regular reabsorption. If you decrease that pressure, what will happen to sodium reabsorption? Decrease. Okay, and so will water also decrease its reabsorption. So water, sodium, chloride, everything. So reabsorption pressure is also very important to be kept. And this is done by the balance of the forces. Some forces are modular in the blood vessels and some forces are modular it is in the interstitium, you know that, right? Okay. But one by one you are talking about what main hormones or factors which are affecting the sodium. Aldosterone definitely is on top of the list because aldosterone is the chief controller for the sodium, if you see. For sodium reabsorption and potassium secretion, yes, number one, okay? And then it is also doing some water, it is also doing some hydrogen ion secretion, if you remember, okay? Aldosterone has multiple functions, not one or two functions. At least 5 different functions have been identified by us for the aldosterone. Do you remember that? Sodium, chloride and water, all going inside. Potassium and hydrogen into the lumen, and then it depends what happens to them, okay? Catecholamines, they are also some reabsorption acting in the initial part. Do you have questions? Are you clear about that?
Yes.
Okay? Catecholamines, okay? Angiotensin 2, well we don't, yeah, exactly. We did not talk about the angiotensin in terms of sodium when we were discussing the regulation because, yeah, we talked about vasoconstriction or the GFR and everything, okay, but we did not talk about the sodium. But it does have some effect on the sodium also. That is important. Sodium hydrogen counter transport, it has an effect. Actually, many hormones out of these have some minor effects also, which we don't discuss actually. This is the issue, because it is out of our scope. There are so many mechanisms in the kidneys which are happening and we don't discuss those mechanisms because then it will become too lengthy and too complicated. In advanced studies, if you go in nephrology, you will study. Right now we are only doing the basic mechanisms and the basic functions of everything so that you can handle all those things. You are not doing post-graduation, you are not going for the higher studies right now. You must know the basic and fundamental functions and uses of everything, alright? So if anything comes new, take it and accept it that if you have not done it before, it doesn't matter, okay? Because it may come at some time later. All the complete functions of anything will not be mentioned anywhere. Whenever you have studies going on, you will find new things and new things really, okay? So don't get confused about it, just have an acceptance. ANP, atrial natriuretic peptide, from the heart, from the muscles of the heart, atria, goes to the kidney, Hudaf's kidney, acting on the kidney, and it is inhibiting the reabsorption so that extra sodium can go out. So whenever you have hypervolemia or you have hypernatremia, both things, hypervolemia, hypernatremia, they will have to affect the kidney so that you get rid of actually both things, 2 in 1, okay, volume and salt at the same time, right? Alright, so it's working on the glomerulus for the filtration and then it's working on the next station for some parts of the tubules where it can cause inhibition of the reabsorption. Alright, and by doing this, does it have a direct action on the renin and aldosterone? Well, it does affect the secretion of these hormones directly or indirectly. Leave that, okay, but it has an effect. Endothelins and PGE2, they are basically, endothelins are the releases of the damaging tissues or the damaged tissues, you know, that whenever there is a trauma. Prostaglandins both, in terms of normal tissue as well as damaged tissues, both can release prostaglandins, okay? And definitely they are working and they are trying to inhibit the sodium, and it means they are promoting the sodium excretion in that sense, alright? Pressure diuresis and natriuresis, whenever you have high pressure in the system or any effect of blood pressure which is coming on the kidney, well, kidneys usually handle the blood pressure very well and they don't allow the blood pressure to excrete large volumes of sodium and water, okay? To some extent, yes, under normal conditions. But since kidneys have a very nice auto-regulation mechanism, this auto-regulation tries to control the situation and minimize the excess of natriuresis and diuresis. But sometimes kidneys are abnormal, diseased, and then their auto-regulation is not working very well. If the autoregulation is harban, it's not working, then you can expect that a slight rise in the blood pressure will cause a big excretion of sodium and water from the kidney, salt and water excretion, okay? But under controlled conditions, under autoregulation, that change is a little. Either the blood pressure has to go very high or it has to go very low. Only in those conditions will kidney be affected. But otherwise, if your autoregulation is good, then don't expect anything much. It's very well controlled, okay? Now, opening the issue here, you have any question about sodium? Is it okay? Alright. Potassium. Levels, narrow range, you know that. Very little, we talked about that. Very significant. Can't move here and there much because abnormalities can cause very quick clinical features or symptoms and signs, and you will definitely see the manifestations in the neuromuscular tissues, in skeletal muscles, in cardiac muscles. You gave the answers last time also, that heart is affected, the skeletal muscles will be affected, and later you may have the involvement of the smooth muscles as well. Okay? And of course the nerves are affected because action potentials are affected if you have an imbalance of the, right? Yes. Okay. The terms are hyperkalemia and hypokalemia for the excess and for the deficiency of the potassium respectively. The balance means the balance of intake and output. Sodium intake was somehow controlled by our psyche or the hypothalamus. Do you remember that? Yes. Not that we see in potassium. We are not sure about any potassium appetite center or potassium controlling center module in the brain. We have not detected anything as yet. Okay? So we are not sure about it. We don't make any comment on that. So we say, we don't know. Non-specifically, we don't know about what mechanisms are controlling the intake. Probably it's the eating, and then maybe at the level of the GIT it is controlled to some extent, absorption or something like that. We're not sure about that. If you're not sure about that, you cannot make a definite comment on that. So anyway, potassium output is the main feature, and potassium output is mainly handled by the kidneys. Okay? It's very, very important for the kidneys to handle it very cautiously, very correctly. Well, in the kidneys, if you go back to the picture of the reabsorption, first of all, let's decide what kind of happenings are there with the potassium in the kidney. Filtration, yes or no?
Yes.
Free filtration, nobody can stop potassium because it is coming in plasma, it's coming in the filtrate, and it is there in the tubular fluid. So the filtered load is there. Now you have to deal with the filtered load of potassium. What is happening with the potassium? Now, after coming in the tubules, what is your expectation? Will it be reabsorbed? Yes or no?
Yes. Yes.
Alright. Major part of it will be reabsorbed? Yes or no?
Yes.
Definitely. You can't lose potassium. You already have a little amount of potassium in the body. So you have to be very, very specific and precise about its reabsorption. So reabsorption is very well handled in that one. Okay? Apart from reabsorption, if you come to the next step, do you think potassium is a kind of an ion which is secreted by the kidney tubules? Yes or no?
Yes.
Okay. Well, yes, because potassium is very well handled by some hormones, and a fine control of hormones can cautiously control the secretion of the potassium also. So potassium reabsorption is mainly the obligatory type, or it happens by itself because there are definite mechanisms present. Okay? But potassium secretion is mainly controlled by the hormones. Okay? I'm not saying that the potassium reabsorption may not be affected by the hormones. Well, again, it is not a part of our discussion because it is an advanced discussion. But just to make it simple, potassium reabsorption mainly done by itself, okay? And some of the factors are affecting its reabsorption, but its secretion is mainly controlled by hormones. So overall, you say the potassium output is controlled by hormones and other factors of reabsorption in the kidney. Finally, how much is going in urine? You have to see that. Okay? So the main regulator hormone of the potassium definitely, just like sodium is. And you know, if you are comparing, you are looking at aldosterone, and you have two things, sodium and potassium there, and you want to see what is the relationship of sodium with the aldosterone and potassium with the aldosterone, and which out of these two is more important and more stimulating. Definitely potassium is more important, and aldosterone is much more sensitive to potassium as compared to sodium, because sodium is kathir and potassium is very little, as you know. Okay, so if I say just make a list of the regulators of the aldosterone or the aldosterone secretion, and if I give you a list of different substances, for example, I am giving you, okay, you have sodium, you have hydrogen ions, you have chloride ions, you have potassium ions, and you have one more thing, which is angiotensin 2. I am giving you 5 choices, okay? Sodium, chloride, hydrogen, potassium, and angiotensin 2. Now, out of that, you have to make a list of priority. What is your tarjeeh actually here? So what will be your choice for that? Potassium and so you will keep two things very on top of the list. You will have angiotensin 2 and potassium. These two are working takriban equally, and they are going. So the chief stimulators of the aldosterone secretion, you will come up and you will pick two things, and you will say, okay, these are the two on top. Remaining are going down. Let's not talk about them. The most important is, okay, with the if you see, sodium will come next after that. Okay, so first on top of the list, angiotensin and potassium. So out of the ions, definitely it is potassium. Out of the hormones, if you consider, angiotensin is the most important. Alright? For the aldosterone regulation. Okay. You will inshallah do it in detail when we go to the endocrinology, which is coming next, right? Yes. After that, very shortly. Great. Okay. Potassium regulation. Okay, it's a very simple chart. If you follow this chart, see, start from the center of the chart. That, for example, the potassium level in the blood is increasing. Starting from that side, this is the increase and this is the decrease here. Okay, and see, as the potassium level increases, what is happening next in the body? What do you expect? This potassium is stimulating someone, and that we already discussed. Aldosterone. Well, that aldosterone will come into the blood, and that will bring about some changes, definite changes. So what will happen? Potassium was will increase. Okay. Now aldosterone is secreted. This aldosterone will go to the kidney. What will it do in the kidney? It will promote the secretion of the potassium, and more secretion will lead to more excretion of the. So that increased potassium will increase the excretion, and this level will drop back to takriban normal, isn't it? The high level of potassium in the plasma will gradually come down and okay? Just opposite happens when you have a low potassium. Already this is also detected, and then you will have inhibition of the aldosterone. If you inhibit the aldosterone, the opposite effect will happen. Okay? You will get the potassium back. Its secretion will decrease, its excretion will decrease, and the body saves potassium. The plasma potassium will gradually increase, and it will be okay. Alright? But this is the whole cycle. You can see cycle is going like this or cycle is going like that. It's very simple. Without looking at it, you can predict the changes happening in the body. It's so simple. Okay? You must know the relationship between the potassium and the aldosterone. That's it. Alright? Alright. Potassium, very well handled by the kidney. And let's have a look. Reabsorption, yes. Again, same like sodium. Same like water, isn't it? Loop of Henle, again, it's same. Okay, takriban same. 65 and 27%, 25-27% for sodium, same here. Almost the same thing is going on. Some from distal convoluted tubules also. Okay? Alright. See, 65 plus 27 gives you how much? 92%, I think, right? 92 plus 4% reabsorb more. is giving you 96%. So far till distal tubules, 96% has been reabsorbed. But now if you see the percentage which is going in urine, well, you say it's 12% going and you say you have only 4% baki. It means 8% is added or 8% is secreted. The final output in the urine has to be seen in two forms. Some which is not reabsorbed, yani takriban 4%, and some which is secreted, yani which is 8%. 8 plus 4 will give you a total of 12. So that's why you see 12. Because otherwise your calculation is showing the error. How can you have that? You are getting 8% by secretion. Alright? I think I'm clear about that? Okay. Because it's very simple. Alright. Many things. And interestingly, you will come across some new things. And I told you, if you come across new things, don't get confused. You may have some new events coming here. Alright. Let me show you something. This is something which is about the proximal tubule, potassium in different ways. It is reabsorbed and it is getting reabsorbed from the paracellular pathways, and some is getting secreted from the channels also, and from the backside also it is going through the channels. Different transports. I don't think you have seen this kind of transport before. Did you see that one? Before? Potassium chloride co-transport. I think we did not discuss that, isn't it? Okay. Well, there are some very special transports which we did not discuss because it would be very confusing to remember like 20, 25, 30 transport mechanisms. You'll see, how can I remember all those things? Okay. So that's why we go for the main things, main or the basic things. But in the kidney, you have some other special transport mechanisms like potassium chloride co-transport, which is also there, and it is happening. Okay, so this is now shown here. Nothing new from here. I think this is the old slide which we have already seen. So the big glucophenolate, sodium potassium chloride, and counter transport, sodium potassium. So everything is old, everything is known. We all know about it. Okay. Sodium potassium channels module in the lumen, no problem. Sodium potassium pump module in the distal tubule principal cells, no problem. Collecting ducts, no problem. Same thing, nothing special for potassium. Identify something new which you have not come across in this slide. In this slide, identify which is new for you and you are not familiar with that. What do you think?
The exchange between potassium and hydrogen?
Yes, because I don't think we have discussed this kind of an exchanger. Potassium hydrogen counter transport. We talked about sodium and hydrogen, but this is jadid, something new which we are introducing. Okay, this is also module in the cell, specific cells. Okay, and because that is not a very major mechanism, it's only a contributing mechanism. We did not discuss in the beginning, but this mechanism is present. This mechanism of potassium hydrogen counter transport. I'm sure you remember one more area, a very famous area of the body where this potassium hydrogen counter transport is there, and you have done it.
Air. Right,
Yes, dear. Thank you very much, Abdullah. Actually, I was talking about some other area, not the kidney, and Abdullah identified that. He said parietal cells of stomach. Do you remember that? The proton pump, and you use the drugs for the ulcer, proton pump inhibitors. Omeprazole, lansoprazole, and so many drugs which inhibit the proton pump. A very famous pump. You know, hydrogen ions are secreted in the stomach for acidity, isn't it?
Yes.
These are secreted by the same pump, potassium hydrogen pump. Is this pump primary or secondary? What do you think here? Over there in the stomach also, is that pump primary? Okay, with the help of the ATP. Okay, so the same pump is there also. This kind of pump is also module intracellularly at different levels of the body. Inshallah, it will come later when you study all other areas. You will be knowing all the pumps and all the areas where this kind of transport is present. Okay, so by this mechanism, these are the happenings in the collecting ducts. Okay, you are secreting the potassium. Okay. And you are reabsorbing the potassium by different mechanisms. This mechanism of the potassium hydrogen, is it for reabsorption or for secretion? What do you say?
Reabsorption.
It's reabsorption. From the back side of the cell, look at the direction of the potassium. Is it for the reabsorption or for the secretion?
For secretion.
For the movement through the channels. I'm saying the channels.
For both of them. Both.
Let me put my question again. Look at the back side of the cell. Some mechanisms are shown.